Welcome to Expert Perspectives on Obesity Management, presented by Cedars-Sinai Medical Center at Diabetes Series Live. My name is Tracy Mitchell, and I will be moderating today's session. You are tuned into the first live session of today's program titled, What's New in Pharmacotherapy for Obesity with Dr. Louis Aronne. Today's session is a live interactive program that allows us to take questions in real time throughout the presentation. I encourage you to send in your questions anytime by typing them in the box located at the lower left-hand side of your screen. I'd now like to introduce our presenter, Dr. Louis Aronne, Professor of Clinical Medicine at Weill Cornell Medical College. In addition, he is the Director of the Comprehensive Weight Control Program at New York Presbyterian Hospital, Weill Cornell Medical Center. Welcome, Dr. Aronne.
Thank you very much, Tracy. It's a pleasure to be here.
Absolutely. I will now hand the program over to you.
Thank you very much. Welcome, and welcome to all my friends who are watching. I really appreciate your tuning in. Today we're going to talk about the ins and outs of pharmacotherapy. I'm going to give you a brief introduction on the health problems surrounding obesity, why they are caused by an increase in body weight, how the body responds to different stresses, and how that results in obesity. And then we'll talk about the medical management of obesity, some of the new drugs that have been approved and some that are on the horizon. These are my disclosures. Now, one of the most interesting things we've learned over the past 10 years in the field of obesity is that the fat cell is an important endocrine organ, and it produces hormones that are critical for the normal functioning of the body, maintain blood pressure, for example. But at the same time, if those hormones are produced in excess, they add up to produce many of the diseases that we now associate with internal medicine, with the practice of medicine. So, for example, high levels of insulin, high levels of estrogen, high levels of the inflammatory hormones have been associated with complex problems like breast cancer. People who are most interested in obesity treatment right now seem to be the cancer specialists. If we go back just 10 years, having a cancer was an absolute contraindication to obesity management. And yet now it looks like treating obesity is an important therapeutic addition to chemotherapy and other types of hormonal therapies in the treatment of hormonally sensitive cancers. When we look at the list of diseases associated with obesity, it seems like almost every organ system is involved. When we look at the cancers, for example, more than 10 cancers, the biggies: heart disease, dyslipidemia, diabetes, non-alcoholic fatty liver disease, sleep apnea, the list goes on and on. In fact, Dr. Lee Kaplan and his colleagues at the Mass General have added this all up, more than 60 illnesses that are the direct result of increased body fat. And let's be clear, it doesn't look like it's necessarily the diet, but an expansion in adipose tissue mass that can lead to this. Now, clearly some people can be healthy if they're at an increased body weight, but other people are very unhealthy. Other people are very unhealthy as a result, and we've spent too much time ignoring the obesity and focusing on the complications. And I believe that we're getting to the point where treating the obesity is going to become the norm. I see a shift going on in the care of patients where treating obesity is moving its way into the mainstream of medical care. Here are new guidelines from our colleague Alan Garber and the others at the Association of Clinical Endocrinologists. This is their new obesity treatment guideline, and it's a complication-centric model. What does that mean? It doesn't mean that you treat every single person who's 5 pounds overweight. What it means is that treating obesity is a very important way to manage complications that we associate with obesity, and the more complications that somebody has, the more aggressively we manage the patient. If we look at this table, which is complicated, you see the yellow arrow there on the left side. It points to the introduction of medical therapy and the fact that it can begin with a BMI of 27 to 30 if someone has complications, and for anyone with a BMI of 30 and above, especially if they have complications. The typical patient we see in our program at New York Presbyterian Weill Cornell Medical Center is typical of the academic obesity treatment programs, and there are now dozens of these around the country. BMI of 37, 6 to 8 medications, plus sleep apnea. that is a typical patient that we see. Someone who is on the verge of needing surgery if our treatment doesn't work. And I want to point out that it's not what we do versus surgery. We see people who've had surgery and they're not succeeding. We also many times encourage people to have surgery, but they just don't want it. They choose not to have it. And as surgery evolves, I think we're going to see a lot more less invasive surgery being done. It's a very, very exciting area right now for development. But again, getting back to the point of the slide, medical therapy for obesity, when we follow a step care model, is absolutely moving into the mainstream. If you look at the diabetes guidelines that ACE has come out with in 2013, it includes treatment of obesity, including medical therapy, before moving to some of the treatments for diabetes, some of the traditional treatments for diabetes. So they're utilizing a weight-centric approach to the management of type 2 diabetes, and I'm very enthusiastic about that trend. I think our patients are going to be feeling a lot better. They're going to do a lot better if we focus on their weight as well as their glucose, instead of just trying to control the glucose and just forget about the weight. It doesn't matter if the patient gains 20 or 30 pounds. I think that we now have enough medicines in our diabetes armamentarium, in our obesity armamentarium, to move to the weight-centric approach of these diseases. I just want to talk for a couple of minutes about the role of the hypothalamus. And I'm sure many of you haven't thought about the hypothalamus since your anatomy exam, your neuroanatomy exam in medical school. But it's turning out to be an area of a lot of very exciting research. Here's a cartoon of the hypothalamus, and the important points are that many of the organs, all of the organs in fact, that measure how much food comes in, the stomach, the large intestine, the small intestine, and then the organ that holds fat, the adipose tissue, sends signals to the brain, and it all goes through the hypothalamus. All of these signals are integrated in the hypothalamus. It's a switching center, and then signals are sent out to the cerebral cortex and elsewhere in the brain. There's another pathway through the vagus nerve that senses satiety or triggers satiety. And what we're learning is that damage to the hypothalamus, which occurs as a result of high-calorie foods and many other environmental insults, that's the disease of obesity. When we talk about the disease of obesity, we're not talking about some existential crisis. We're talking about physical injury to a part of the brain that transmit the signals from these organs to the rest of the brain. And this is critical. This is critical and is turning out to be a very important part of the story. This is a paper published in 2012, Michael Schwartz and colleagues from the University of Washington, Obesity Associated with Hypothalamic Injury in Rodents and Humans. And in this, they looked at rodent models of obesity, diet-induced obesity, where they give high-calorie food, high-fat, high-starch food to animals. And what they see is inflammation and neuron dropout in the hypothalamus. So there are fewer nerves to send the signals. And the inflammation, unlike inflammation that occurs in obesity, which builds up over weeks and months, this happens immediately within just a few days of feeding the animals fattening food. So we think that this is an incipient event. The inflammatory cells in the brain, glial cells, seem to prevent some of the hormones like leptin from getting to the actual nerves. And these hormonal changes that occur, like leptin resistance, you've all heard that people who are obese, humans who are obese, are resistant to leptin. What is leptin resistance? Could it be that the glial cells, in their effort to protect